Hello, friends. Good morning. So, at the outset, I wish to thank Dr. Anand for having me to deliberate on this topic, NOACs use and the current evidence. So, as you see, this is a quite a big topic. There are quite a few trials. Possibly, you could deliberate upon this topic the whole day. So I'm sure the topic that I'll be covering and the evidence that I'll be talking, there would be significant overlap between the previous speakers. So nevertheless, they're all important trials. So it's good for all the listeners here to have clarity on how these trials are done and what is the current understanding of use of NOACs. So NOACs is newer oral anticoagulants, and the newer nomenclature that is more increasingly used is direct oral anticoagulants. So we'll use the word NOACs in this particular talk. So the topics that I would cover is just the physiological, because when we talk about newer oral anticoagulants, it is important to just have a little overview on the coagulation pathway on which it works. And we'll just look into what are the FDA approved prophylactic indications. So this is very important at the outset to ascertain as to what are the conditions where FDA has approved its usage as prophylaxis. So we'll look into the key difference, because if you look at all the data and all the studies, most of them would be comparing NOACs with another agent, and it has to be another anticoagulant. So I'll try to mainly focus on NOACs as compared with warfarin, which is another vitamin K antagonist. So I wouldn't take studies which compares NOACs versus placebo. So only one study that I would cover is the most recent RTCR trial, which compared NOACs versus aspirin. But otherwise, most of the evidence that I would cover would be NOACs versus its other competitor, or it's another anticoagulant, which is vitamin K antagonist warfarin. And when you look at the evidence, there's a whole lot of evidence. So one possible article which tries to encompass all the evidence that is prevailing is one meta-analysis which came in Lancet. It's the largest meta-analysis encompassing 72,000 patients, covering around 48 randomized controls. So this possibly will give a very comprehensive sort of a overview on the evidence of NOACs. Then we'll talk about four landmark articles, which I'm sure many of you would have heard in various formats, which is imperative that we talk about these landmark articles, which are compared NOACs versus warfarin. So this is an interesting article that has looked into NOACs versus dalteparin in cancer patients who had VTE to prevent further occurrence of VTE. And then this is the fourth one I picked up is important as well, because we do get a lot of CKD patients on dialysis, whether NOACs are safer and is it found to be superior or beneficial. And obviously we need to cover the latest trial that has come in 2024 January in any game, which is NOACs versus aspirin in subclinical AF. So I'll very briefly cover this the sort of important evidence that is prevailing on the use of NOAC. And after talking all the evidence, it is good for all the listeners to have some key take-home recommendations with the use of NOACs, and we'll talk about take-home message. So when you look at this coagulation pathway, which has extrinsic sort of a pathway, and then there is an intrinsic pathway and the common pathway. And as you would see, this you would be reading from in your MBBS days. So the only thing you need to focus on is this 10A and 5A, and your anti-10A inhibitors, which are the newer oral anticoagulants, which are most commonly used, act at this 10A. And this gets converted to thrombin along with 13A converts fibrinogen to fibrin, and fibrin clot is formed. So the 10A that are currently available in the market and in India, rivaroxaban, apixaban, and edoxaban is not available yet, and betrixaban. So these are the currently available worldwide, and apixaban and rivaroxaban are the ones which are available in India. And the direct thrombin inhibitor, which acts on the thrombin, which is needed for conversion of fibrinogen to fibrin, or dabigatran, which is available, and the other ones are ergotroban and bivalirudin. So the only thing you have to remember is there is this extrinsic pathway, there is this intrinsic pathway. Then both of them together lead to common pathway, which starts from 10A interacting with 5A, leading to thrombin, which converts fibrinogen to fibrin. And we need to know where fewer NOACs act. So one group acts for the 10A and one group acts for the direct thrombin inhibitor. So we'll directly jump into what are the approved FDA approved sort of conditions for prophylaxis. So one important area we talk about evidence of newer oral anticoagulants is prophylaxis in orthopedic surgery, which may be knee joint surgeries or hip joint surgeries to prevent VTE. As you see, I just listed all the newer oral anticoagulants. So the prophylaxis in orthopedic surgery is approved for rivaroxaban in 2011 by FDA, approved for apixaban in 2014, approved for edoxaban in 2015. And the second conditions where FDA has approved its prophylactic usage is in the stroke prevention area. So if you look at all the trials, the major body of evidence lies in this sort of a dimension to prevent stroke in patients with AF, and most of the NOACs are approved in non-valvular AF, not in valvular AF. So in non-valvular AF, to prevent stroke, which we call as stroke prevention in SPAF, stroke prevention in atrial fibrillation, it's approved for all these newer oral anticoagulants, dabigatran, rivaroxaban, apixaban, and edoxaban. And these are the years in which it is approved, not yet approved in for betrixaban. And now we'll look into the FDA approved treatment indications for venous thromboembolism. So all these NOACs, including betrixaban, is the recent kid on block, which is approved in 2017. All these are approved for the treatment of venous thromboembolism. And how about ACS, acute coronary syndrome? The approval process is completed for rivaroxaban and apixaban, but it has not come as a formal sort of an approval or as a formal guideline. But this is at any point of time, these are sort of figuring out in some of the guidelines. So this is completed. So, but FDA has not still come out as an approval for usage of these in ACS. So this is a sort of an FDA approved indications. So we'll just jump into what are the key characteristic difference between the NOACs and the warfarin. So there are certain pros and cons of NOACs. So the newer oral anticoagulants, some of the strengths of it is increasingly effective and use it as a fixed dose. There's no need for INR monitoring. And most studies, very interestingly, have shown reduction in sort of a bleeding manifestations with NOACs. And the one of the con or the limitations is it limitations, and obviously it is more pricey than warfarin. So the pros of warfarin is it is bound to the albumin and predominantly excreted by the liver, so it could be used safely in the CKD patients. But the limitations of it is one needs to do INR monitoring when using warfarin, and it has a narrow therapeutic sort of a window in which it acts, and it has huge interactions with lot of nutritional intake or the dietary interactions are something that is common, which either pronounces the effect of warfarin and limits the effect of warfarin, and the response is a little unpredictable. So there is a unpredictability with regard to the response to warfarin. So these are some of the key characteristic strengths and limitations of NOACs and warfarin. So we'll jump into, because the topic for today for me is the evidence. So we'll directly jump into the all the evidence that is available. So this is one article I want all the listeners to pay attention to. This is the possibly the largest meta-analysis. As you see, mammoth number of patients, 71,683 patients, 48 randomized controlled trial. It's come in Lancet in 2014. So comparison of the efficacy and safety of NOACs with warfarin in patients with atrial fibrillation. So here they had patients 42,411 in NOACs and 29,272 in warfarin, and it did encompass all the key landmark articles like Rely, Rocket AF, Aristotle, and Engage AF. And these are some words which you would have listened. I'll go into the little detailing of these trials. So most of the trials that I'll be talking have looked into usage of these NOACs to prevent the stroke and systemic embolization. So I've just put pictorially as arterial or venous thrombolism and mainly systemic embolization. So if you see, this is a hugely positive meta-analysis. NOACs significantly reduce the risk of stroke or systemic thrombosis as compared to the warfarin, and they were all statistically significant. Most interestingly, this meta-analysis shows that all-cause mortality also there was significant reduction with the use of NOACs when compared to warfarin. In patients with in a subgroup analysis they made in patients with non-valvular AF with APLA, in patients with antiphospholipid antibody, when they compared vitamin K antagonist and rivaroxaban, vitamin K antagonist was found to be superior. And again, just detailing into this particular study, they looked at the IC bleed. See, the main sort of a concern that we would have with the use of these NOACs is the IC bleed. And interestingly, they found in this meta-analysis, the risk of IC bleed was significantly less in the NOAC group as compared to the warfarin, which means it is very good, especially when we portend the risk of patients developing IC bleed. And the GI bleeds was higher with the use of NOACs. As you see, the relative risk was 1.25, and that was statistically significant. So there was a mortality benefit, there was a stroke reduction, there was systemic thrombosis reduction, IC bleed reduction, but the GI bleed was high with the NOAC group. And here they did a subgroup analysis about low dose NOACs, because we have differential dosage of NOACs. We look into the dosage in recommendation. With the low dose NOACs, they found that the stroke prevention and the systemic embolization prevention did not happen. As you see, it did not attain statistical significance. In fact, with the use of low dose NOACs, they found there was increase in the risk of the stroke or systemic thrombosis, and that attained statistics. So, which means when you're using NOACs, it's no good using low dose, because that may increase the risk for stroke and definitely did not prevent stroke. Rather, high dose NOAC will show you the dose in the recommendation. But the risk of bleeding definitely was less when low dose NOACs was used, and that attained statistical significance. So these are some of the subgroup analysis they did. So the conclusions of this meta-analysis was NOACs was favorable when you look at the risk benefit sort of balance. The benefit outweighed the risk, although there was a risk with GI bleed, but that could be addressed with whatever medical or little interventions, but it did not endanger the lives, because all-cause mortality was significantly less with NOACs. So the NOACs was favorable in reducing the stroke, reducing the mortality, and reducing the IC bleed. So this is a very strong, compelling sort of an evidence, largest meta-analysis that possibly you can keep in mind. So this is an, another interesting sort of a study, NOAC versus dalteparin in patients with cancer. It was a systematic review and meta-analysis. So in patients with cancer who develop venous thromboembolism, whether the use of direct oral anticoagulants or NOACs as compared to dalteparin, low molecular weight heparin, did it show benefit in preventing recurrent venous thromboembolism? So in this particular meta-analysis, it showed that the NOACs significantly reduce the risk of recurrent venous thromboembolism as compared to dalteparin. This is in patients with cancer. Because increasingly, we are seeing cancer patients who are at a very high risk of develop VTE. Use of NOAC was found to be superior to dalteparin to prevent recurrent VTE. And when they looked at major bleeding, it was similar between DOACs and dalteparin. But non-major clinically significant bleed was more with newer oral anticoagulants at 11.1% as compared to dalteparin, and that also attained. So all the studies, if you see, they say the risk of bleeding, it tends to be a little higher, but IC bleeds, most of the studies are shown to be less with newer oral anticoagulants. But this is non-major clinically significant bleed was higher in DOACs. This is in cancer patients. So we'll just very slowly dwell into the key landmark articles which we need to be aware. So all these landmark articles that I'll show have come in NEJM. But a word of caution, most of these are pharma funded, and they are hugely pharma funded trials, and none of them are institution driven trials. So the Relight trial came in NEJM in 2009, comparing dabigatran versus warfarin in patient with atrial fibrillation, mainly come with Canadian and Dutch authors. So here all the studies had good number of patients, 18,113. Here they compared two doses of dabigatran. So in one group they had 110 milligram dabigatran compared to warfarin. So they showed stroke reduction and systemic thrombosis was similar between the two groups, and the bleeding was lower with dabigatran. So they did not show superiority of dabigatran, but the higher dose of dabigatran, 150 mg per BD, showed significantly reduced risk of stroke and systemic thrombosis, and even the bleeding was similar. So goes on to show that 150 mg BD of dabigatran had a better benefit than 110 mg BD of dabigatran. So the Rocket AF trial, so this is rivaroxaban versus warfarin in non-valvular atrial fibrillation, again a pharma-funded trial, come in NEJM in 2011. So again, good number of patients, 14,264 randomized between rivaroxaban and warfarin. They looked at the stroke and systemic thrombosis. It was a non-inferiority study, so there was no difference between rivaroxaban, and it was non-inferior, which means rivaroxaban performed as good as warfarin, and bleeding also there was no difference. And when they looked at IC bleed, intracranial bleed was less in rivaroxaban as compared to warfarin. So wherever I showed thumbs up, there was some benefits with the use of NOACs, and the fatal bleed also was significantly less in rivaroxaban as compared to warfarin. Goes on to show it was non-inferior, it was as good as warfarin, but the key benefit is it showed reduction in the IC bleed and the fatal bleed, which is also very important when you're using anticoagulations. Then came this Aristotle trial, where apixaban versus warfarin in patients with atrial fibrillation. Good number of patients, 18,201. So randomized between apixaban, 5 mg BD, and warfarin. Here they looked at stroke and systemic thrombosis was significantly less with the use of apixaban as compared to warfarin, and major bleed also was significantly less with apixaban, and IC bleed also was significant. So this is a hugely positive study, Aristotle, which leans towards more compelling benefit of newer oral anticoagulants, and there is more benefit with reduction in IC bleed, reduction in stroke, and reduction in major bleeding. So that is about Aristotle. Then this is Engage AF TIMI trial. This is comparing edoxaban versus warfarin in patients with atrial fibrillation. Big group of patients, 21,105. So they compared high dose edoxaban, low dose edoxaban, and warfarin. 60 mg of edoxaban, 30 mg of edoxaban, and 7,035 in each of these patients. So the stroke prevention and systemic thrombosis, it was non-inferior to warfarin in all the doses, but edoxaban higher dose showed a trend towards favorable benefit in reducing the risk of stroke and systemic thrombosis. Lower dose, so we saw the similar trend with dabigatran, where higher dose was more beneficial, but lower dose was non-inferior. It was very similar. Lower dose in fact showed unfavorable trend, but the higher dose showed more towards favorable trend with edoxaban. And again, like dabigatran, like apixaban, the major bleed was less with NOACs as compared to warfarin, statistically significant, and death due to cardiovascular events also was significantly less in edoxaban group as compared to warfarin, and that was the statistical significance. So, which goes on to show, if you see, most of the studies are showing benefit with NOACs in reducing the risk of IC bleed or major fatal bleed, and some of them showing benefit with regards to prevention of stroke and systemic thrombosis. So this is an interesting sort of an observational study. It's a retrospective study of benefit of apixaban in end-stage kidney disease who are on dialysis with atrial fibrillation. So large group of retrospective data, 25,523 patients. Small group on apixaban, 2,351 compared to 23,171. These are end-stage renal disease or dialysis who received NOACs. So they looked at stroke reduction and stroke prevention and systemic thrombosis. There's no difference between apixaban and warfarin. But here, when they compared higher dose versus lower dose in the retrospective data, 5 mg BD and 2.5, again goes on like dabigatran, like edoxaban, higher dose had a benefit, significant benefit in reducing stroke prevention and reducing systemic thrombosis, attained statistical significance at high dose. This was a subgroup analysis they did, and high dose also showed reduction in the risk of patients dying with patients with end-stage renal disease. So again, goes on to show dabigatran high dose more effective in sort of reducing the stroke or mitigating the stroke and systemic thrombosis. And even edoxaban higher dose was shown to reduce the stroke and reduce the risk of systemic thrombosis. In a kidney failure also, dose reduction is something one possibly should think of avoiding with apixaban, although recommendation says some dose adjustment is needed. And major bleed also was significantly less with apixaban when compared to warfarin in end-stage renal disease. Goes on to show that these are the agents which are safer even in the end-stage renal disease. So just coming to the last sort of a trial that I'll be discussing, which just came in January 2024, apixaban for stroke prevention in subclinical AF. These are all clinical AF, subclinical AF. And it is shown that patients with subclinical AF are at 2.5-fold times higher risk of developing stroke and more than one third of elderly patients with hypertension do have subclinical AF, and these patients are at a risk of developing stroke in 1% per year. So this study was done to address whether the use of apixaban reduces the risk of the stroke. Here, the mean sort of a CHAD-VAS score was 3.9 plus or minus 1.1. The CHAD score is usually in the range of 0 to 9, 9 portending highest risk for developing stroke. So they had 4,012 patients, 2015 in apixaban group and 1,991. Again, shows the stroke prevention and systemic thrombosis prevention was significantly less with the use of apixaban. So the number of strokes was 55 compared to 86. It amounted to 0.78% per patient year compared to 1.24% per patient year, attaining statistical significance. And they looked at the bleed. Major bleeding was significantly higher. Only this is one study, RTCR study, which shows all the previous studies you saw, Aristotle, Engage MI, and Rely, all of them tended to show lower risk of bleed. But this is one study where it showed major bleeding was high in the apixaban group, and that attained statistical 1.71% versus 0.94% in aspirin. But as you see, this trial was comparing not apples to apples, but apixaban was compared with aspirin because all the previous trials you saw NOACs being compared with warfarin. So that's why the major risk of bleed was higher with apixaban as compared to aspirin because aspirin is antiplatelet, apixaban is NOACs. And the fatal bleed surprisingly was higher in aspirin and lesser in apixaban. So this was the most recent trial, which again goes on to show that these agents are successful in preventing the stroke and systemic thrombosis. But as you see, this is a subclinical affair compared with aspirin. So just coming, so those was all about the evidence. So we'll very briefly to summarize all the evidence into what has come as a accepted recommendation is most recommendations come in stroke prevention in patients with non-valvular AF. So this is something you can keep as a take-home message. So apixaban for stroke prevention in AF, standard dose is 5 mg. Dose reduction to 2.5 mg twice a day may be needed if patient's age is more than 80 years or if patient's weight is less than 60 kgs or creatinine more than 1.5. So again, here you may have to exercise little discretion because we saw that study where the benefit was more in even end-stage kidney disease with 5 mg or BD of apixaban. So that is something you can keep in back of your mind. And dabigatran 150 mg BD and dose reduction is not needed. And edoxaban 60 mg once a day standard dose. Dose reduction to 30 mg may be needed in patients who weigh less than 60 kgs or creatinine clearance, which is between 15 to 49. Rivaroxaban standard dose is 20 mg OD. Dose reduction of 15 mg OD in patients with creatinine clearance less than 15 to 49. And what about liver failure? Child C cirrhosis, none of these NOACs can be used. Child B has to be used with caution. Rivaroxaban cannot be used in child B. In child A, all of them can be used. Abigatran, apixaban, edoxaban, and rivaroxaban. So what about recommendations in patients in AF with acute coronary syndrome? It is very similar to stroke prevention in AF. So 5 mg BD, 2.5 mg in patients with more than 80 years, less than 50 kgs, creatinine more than 1. Dabigatran is the same as previous 150 and 110 mg. So edoxaban 60 mg standard reduced to 30 mg in patients weighing less than 60 kgs, creatinine clearance 30 to 49. Rivaroxaban 20 mg reduced to 10 mg if creatinine clearance is less than 30 to 49. So these are the recommendations for AF. So how about recommendations for treatment? So for the treatment, this is a little different because obviously the earlier one was prevention. Initially is 10 mg BD for 7 days. Only apixaban gets treatment at the outset. Otherwise, all the other NOACs you have to use low molecular weight heparin initially. 10 mg twice a day for 7 days, followed by 5 mg BD. For dabigatran, you had to overlap it. The initial therapy is low molecular weight heparin or heparin, and then you can change out to 150 mg BD of dabigatran. Rivaroxaban, you can give at the outset 15 mg BD into 21 days, followed by 20 mg once a day. Edoxaban, heparin or low molecular is the initial choice, after which it can be changed out to 60 mg OD. So I wouldn't expect most of you to remember all this. You can refer all this, you create a protocol and keep it in your ICU and refer to this when you have the patients to treat with it. And long-term prevention of recurrent venous thromboembolism, especially in patients with cancer. So apixaban 2.5 mg BD and dabigatran 150 mg BD, rivaroxaban 10 mg OD, and edoxaban 60 mg OD. So those are sort of accepted recommendations that is endorsed by many of the guidelines. And what about the recommendations for VTE prevention in orthopedic patients? Apixaban 2.5 mg twice a day, dabigatran 150 mg OD, rivaroxaban 10 mg OD, and edoxaban 30 mg OD. And how about in post-acute coronary syndrome without AF to prevent atherothrombosis? Only rivaroxaban is sort of suggested at 2.5 mg twice a day. It's a small dose along with aspirin and P2Y12 inhibitor. So these are some of the recommendations that has been endorsed by few of the guidelines. So the take-home message is NOACs, newer oral anticoagulants, have good physiological plausibility that they work on the physiological pathway of intrinsic and extrinsic on 10A inhibitors and direct thrombin inhibitors. But NOACs has good evidence both in prophylaxis and treatment. In prophylaxis, mainly in the stroke prevention, all the major trials are done in stroke prevention, in in atrial fibrillation following acute coronary syndrome, or preventing venous thromboembolism in orthopedic surgery. So there's a good sort of an evidence in these conditions. Treatment, there is good evidence for treating venous thromboembolism, and many of the drugs one needs to start with low molecular weight heparin and then change over to NOACs, but only for rivaroxaban and apixaban, you could start off upfront without the need for low molecular weight heparin. And treatment is also to prevent recurrent venous thromboembolism. Someone who's had a VT, mainly in cancer patients, there is a good evidence. But the caution one needs to exercise is all the studies, all these major trials, Rocket trial, Aristotle trial, Relight trial, all these have come in the top journal that we look up to NEJM, but all these trials are pharma funded. So one has to keep that in back of mind. So, but there is good evidence. So just look into from that perspective and exercise your deliberation. So thank you one and all. I request each of you to submit your valuable work to Journal of Acute Care, which comes out every 3 to 4 months, and can visit my website www.drdeeprangappa.com to read to this lecture. So thank you one and all.